No sooner did health departments across the country start releasing early COVID-19 data than a troubling but predictable pattern emerged. Black, Latino, and poor communities across the United States were hardest hit, experiencing some of the highest rates of infection and death. What followed was a familiar story for many pundits and medical experts, telling us that these disparities were due to group differences in factors like chronic disease risk, health behaviors, and adherence to social distancing orders. In other words, these messages implied it was something about these groups, their bodies, their actions, their behaviors, that made them most susceptible. But as a sociologist and demographer who studies population health, I knew that these messages were incomplete and misleading, and they ignored a fundamental truth, that social inequalities in health and in COVID-19 infection stem from group differences in exposure to social and economic conditions. And if that we really want to understand why we see such disparate patterns of COVID-19 infection and death, we must first examine and acknowledge how broader social inequalities, including racism and social class inequality, directly shape COVID risk of infection, pattern the availability of testing and treatment resources, and directly shape individuals' ability to safely social distance. This pandemic is serving to shine a bright spotlight on existing fault lines in American society that shape where and in what types of housing people live, their jobs, and whether they have paid sick leave or the ability to telework, individuals' access to health care, their exposure to discrimination and other daily stresses that erode their body's cardiovascular function and immune systems. This unequal patterning of resources and risk directly impacts who dies and who gets sick from COVID-19, from chronic disease, and from a host of other causes. We're seeing this play out now in really stark terms, with poor Black and Latino workers needing to go to work despite social distancing orders, with community testing sites being disproportionately located in upper and middle income white areas, not in the neighborhoods where people face the greatest risk of infection. We see this with hospital protocols that allocate critical resources like ventilators according to prior health risk and likelihood of survival, which further exacerbates inequalities in survival and in death. And while this sounds bleak, what this tells us is that these inequalities were not natural, they're not inevitable, but rather these fault lines were created by policies and practices that segregate neighborhoods and workplaces, that allocate resources like healthcare according to ability to pay, that unfairly funnel groups into jobs without paid sick leave or without living wages. Importantly, these inequalities are not natural. We created them, so we can undo them. We can extend paid sick leave and living wage laws. We can design economic policies and relief packages according to principles of equity and restorative justice. We can allocate testing and protective equipment based on community need and not on community privilege. We have the social and economic policy tools to reduce these inequalities in health. My hope is that this pandemic gives us the political will.